Picture this. A 42-year-old woman walks into your clinic. She had a partial resection of a low-grade glioma 18 months ago. Grade 2 oligodendroglioma. IDH mutation positive. Since surgery, she has been on watchful waiting. Serial MRIs. No chemo, no radiotherapy. And every scan, she sits in your waiting room wondering if this is the one where the tumor has grown.
And until now, that is all we could offer. Watch and wait. Because for grade 2 IDH-mutant gliomas, there has been no medical therapy proven to delay progression after surgery. The only options were radiation and chemotherapy, which carry real cognitive costs, especially in younger patients. So you hold them back until the tumor grows.
Right, but as of this week, that conversation changes. Vorasidenib, brand name Voranigo, has just been listed on the PBS. It is the first new treatment for this type of brain cancer in over 20 years, and it comes from the INDIGO trial, a phase 3 randomized study published in the New England Journal of Medicine.
Let me stop you there. 20 years with nothing new, and now suddenly we have a drug. What did the INDIGO trial actually show? Give me the numbers.
331 patients with residual or recurrent grade 2 glioma, all with IDH1 or IDH2 mutations, all had surgery as their only treatment, no prior chemo or radiation. They were randomized to Vorasidenib 40 mg daily or placebo. The primary endpoint was radiographic progression-free survival.
And the result?
A 61% reduction in the risk of progression or death. The hazard ratio was 0.39. At 2 years, 59% of patients on Vorasidenib were progression-free, compared to 26% on placebo. Median progression-free survival was not even reached for the Vorasidenib group. For placebo, it was 11.4 months.
That is a striking effect size. But I want to understand the mechanism. What does this drug actually do?
Vorasidenib is a brain-penetrant oral inhibitor of mutant IDH1 and IDH2 enzymes. In patients with these mutations, the enzyme produces an on-car metabolite called 2-hydroxyglutarate. This metabolite blocks cellular differentiation and drives tumor growth. Vorasidenib shuts down that production, allowing cells to differentiate normally again.
So it is a targeted therapy in the truest sense. It only works if the mutation is present, which means you need to test for IDH status before even considering it.
Exactly. And the testing is already standard. The trial used the OnCarmine-Dx target test, which is commercially available. Any patient with a grade 2 glioma should have IDH mutation testing done at diagnosis because it is both prognostic and now predictive.
Now, the practical question. This drug was costing patients around $28,000 for a 30-day supply. What is the PBS listing actually changed?
From this week, Vorasidenib costs no more than a standard PBS script, $25 for general patients, $7.70 for concession card holders. About 135 Australians per year are expected to be eligible. Adults and adolescents 12 and older with grade 2 IDH-mutant astrocytoma or oligodendroglioma who have not yet needed chemo or radiotherapy.
That is genuinely practice-changing. For a GP in a rural town, this means when you are referring a patient with a newly diagnosed low-grade glioma, the IDH status is no longer just academic. It determines whether they can access a drug that more than halves their risk of progression. Tell your neurology colleagues and make sure the mutation testing is done.
And there was one more finding from INDIGO that is worth noting. Time to next intervention. This measures how long before the patient needs their next cancer treatment, whether chemo, radiation, or further surgery. Vorasidenib pushed that out significantly. The hazard ratio was 0.26, a 74% reduction.
So it is not just delaying scan progression, it is delaying the need for toxic therapies like radiation, which we know causes cognitive decline, especially in younger patients with low-grade gliomas. That is meaningful.
It is, though we should be honest about what we do not know yet. INDIGO was not powered for overall survival, and the crossover design means survival data will be hard to interpret. The median follow-up was under 2 years, and the main side effects were fatigue, headache, and elevated liver enzymes, which were generally manageable.
Understood. But for a disease where we had literally nothing for 20 years, this is a genuine breakthrough. IDH-mutant low-grade glioma now has a targeted oral therapy that is PBS-funded. Test the mutation, start the conversation early.
Let us shift gears. From oncology to intensive care, you have a patient in ICU, septic. They have been started on broad-spectrum antibiotics. The cultures are back. The question every clinician faces is the same. When do you stop?
This is one of the hardest calls in hospital medicine. Stop too early and you risk undertreating. Stop too late and you drive resistance, you increase side effects, you prolong hospital stays. We have all been there, staring at a patient on day 7 of antibiotics, wondering if day 8 is necessary.
The ADAPT-Sepsis trial just published gives us the best evidence yet on how to answer that question. It is a multi-center randomized trial from 41 UK NHS intensive care units, 2,760 critically ill adults with suspected sepsis, 3 arms, procalcitonin guided antibiotic cessation, CRP guided cessation, or standard care.
Procalcitonin versus CRP. This is the head-to-head comparison we have been waiting for. Both are biomarkers that rise with bacterial infection. The idea is that if the biomarker falls, the infection is controlled, and you can safely stop antibiotics regardless of how many days you planned. What did the trial find?
Procalcitonin worked. CRP did not. Patients on the daily procalcitonin guided protocol had their antibiotics stopped about 1 day sooner than standard care. Mean duration of 10.7 days with standard care, dropping to 9.8 days with procalcitonin. That difference was statistically significant.
And CRP?
No difference. Mean duration of 10.6 days, essentially identical to standard care.
1 day does not sound like much, but across thousands of ICU patients, that is enormous in terms of antibiotic exposure, resistance pressure, and side effects. What about safety? Did stopping antibiotics sooner cause any harm?
This is the critical test, and procalcitonin passed. 28-day mortality was 20.9% in the procalcitonin group versus 19.4% with standard care. That difference met the pre-specified non-inferiority margin. so procalcitonin-guided cessation was statistically safe, no excess deaths.
And CRP?
CRP was inconclusive for mortality. The absolute difference was 1.7%, and the confidence interval crossed the non-inferiority boundary, so they could not confirm it was safe. The authors concluded that daily procalcitonin-guided protocols can be recommended for routine use in critically ill adults with sepsis. Daily CRP-guided protocols cannot.
That is a clean, actionable conclusion. Procalcitonin yes, CRP no. But let me push on generalizability. These were ICU patients in the UK. What about ward patients? What about primary care? There have been trials of procalcitonin in lower respiratory tract infections in general practice, and the evidence there has been more mixed.
You are right to flag that. This trial is specific to ICU patients with suspected sepsis who were likely to need at least 72 hours of antibiotics. The procalcitonin protocol involved daily measurement with a structured discontinuation algorithm. When procalcitonin dropped below a threshold or fell by 80% from baseline, clinicians were advised to stop antibiotics. For primary care, the evidence is different. A Swiss trial showed that point-of-care procalcitonin in general practice reduced antibiotic prescribing for lower respiratory tract infections, and the cost-effectiveness data supports it. But those are different settings, different protocols.
So the takeaway for a GP anaesthetist who also covers the rural ED and refers to ICU: if your hospital has procalcitonin available, advocate for a protocolized approach to antibiotic cessation in your septic ICU patients. It safely reduces antibiotic duration. CRP-guided protocols do not, and this matters because shorter courses mean less Clostridioides difficile, less resistance, less antibiotic-associated organ toxicity.
Precisely. The authors noted that the reduction was about 1 day overall, but in the initial sepsis period both biomarkers showed reductions. Procalcitonin sustained that benefit through to day 28. CRP did not. The Bayesian analysis showed an 85% probability that procalcitonin reduced duration by more than half a day. For CRP, that probability was only 13%. Now to obstetrics. Tell your wife about this one. Opioid use disorder in pregnancy is a growing problem, especially in rural Australia. The standard treatment is sublingual buprenorphine or methadone, but adherence is poor, doses are missed, and the consequences include relapse, overdose, and neonatal opioid withdrawal syndrome.
Right. The challenge with sublingual buprenorphine is that it requires daily dosing. Patients have to come to a pharmacy every single day, or take home doses that can be diverted or missed. In pregnancy, that burden is even harder. So the question is whether extended-release buprenorphine, a weekly subcutaneous injection, could work better.
A new randomized trial published in JAMA Internal Medicine in March this year tested exactly that. 140 pregnant adults with opioid use disorder, randomized to weekly extended-release buprenorphine versus daily sublingual buprenorphine, followed through pregnancy and 12 months postpartum.
Small trial, 140 patients. But this is a genuinely hard population to study. What was the primary outcome?
Illicit opioid abstinence during pregnancy, measured as the proportion of weekly urine drug screens that were negative. Extended-release buprenorphine was superior. 82.5% of weekly samples were negative, compared to 72.6% with sublingual, a difference of about 10 percentage points. Statistically significant.
10 percentage points more abstinent weeks. That is clinically meaningful. Was it driven by the pharmacology or by the dosing convenience?
Probably both. Extended-release buprenorphine provides steady plasma levels without the peaks and troughs of daily sublingual dosing, but the bigger factor is likely adherence. With a weekly injection, you cannot miss a dose. You cannot divert it. The medication is guaranteed to be on board. And in a population where missed doses are the main driver of relapse, that matters enormously.
What about the baby? Neonatal opioid withdrawal syndrome is the outcome everyone worries about. Did extended release make that better or worse?
The neonatal outcomes were essentially the same. About 30% of infants in both groups needed opioid treatment for withdrawal. The length of treatment trended lower with extended release, around 11 days versus 15, but that was not statistically significant. One interesting finding: infants exposed to extended release had slightly larger head circumferences at birth, 34 centimeters versus 33.4, which may reflect better overall maternal health and nutrition, but is a secondary finding that needs replication.
And maternal safety?
Here is where extended release looked genuinely better. Serious adverse events during pregnancy were significantly lower, 8.7% with extended release versus 26.8% with sublingual. That is a striking difference, and it persisted postpartum, 6% versus 18.6%.
That is a threefold reduction in serious adverse events, though I noticed that non-serious adverse events were more commonly rated as medication-related in the extended release group during pregnancy, 26% versus 7%. What were those?
Mostly injection site reactions. The weekly subcutaneous injection can cause local swelling, redness, or pain. These were generally mild and did not lead to discontinuation. The authors concluded that the trial supports the use of weekly extended-release buprenorphine for opioid use disorder during pregnancy.
Now, is extended-release buprenorphine available in Australia? Because that is the practical barrier.
It is. Weekly and monthly extended-release buprenorphine is TGA registered and available in Australia, marketed under brands like Bovidal. It is used in opioid substitution programs. Whether it is specifically indicated for pregnancy is something to discuss with the Addiction Medicine Service, but the evidence now supports its use.
For a rural GP, this is worth knowing. If you are managing a pregnant patient with opioid use disorder or referring one to an addiction service, extended-release buprenorphine should be on the table. Better abstinence, fewer serious events, same neonatal outcomes. The weekly injection removes the daily adherence barrier that drives relapse.
Let us close with some quick hits. First, new PBS cancer drug listings this week alongside Vorasidenib, selpercatinib, brand name Retevmo, is now subsidized for patients with locally advanced or metastatic medullary thyroid cancer, a RET inhibitor for a rare cancer that previously had limited options.
And another one?
Tafasitamab, brand name Minjuvi, for relapsed or refractory follicular lymphoma, a targeted immunotherapy that helps the immune system recognize and attack cancer cells. Also PBS listed this week.
And access to Adalimumab, and infliximab, including Humira and Remicade, has been brought in for children with Crohn's disease. Over 40 children expected to benefit from earlier access. These are anti-TNF biologics that can otherwise cost families more than $500 per prescription.
Second quick hit. The PBAC held a special meeting on July 30th to consider expanding the PBS listing for triptorelin 3.75 mg. This is a GnRH agonist currently listed for prostate cancer and precocious puberty. The proposal is to extend it to women's health conditions, potentially including endometriosis and fibroids. Significant consumer and clinical input was received. The outcome is pending.
That could be big for endometriosis management if it goes through. Currently, GnRH agonists for endo are expensive and not widely subsidized. Worth watching for the PBAC outcome.
Third quick hit. A large study of over 15,000 sepsis patients in the emergency department, published in BMC Emergency Medicine, examined the relationship between time to antibiotics and mortality. The finding reinforces the surviving sepsis 1-hour bundle. Patients who received antibiotics within 1 hour had lower mortality. The benefit persisted up to about 3 hours, then diminished significantly after that.
Sooner is better, but the practical takeaway is that the 1-hour target is the right benchmark. Beyond 3 hours, mortality risk rises noticeably. This matters in rural EDs where antibiotic access and staffing can be barriers to rapid administration.
Exactly right. Let us recap. 4 stories today. First, Vorasidenib, brand name Voranigo, now PBS listed for IDH-mutant grade 2 glioma, the first new brain cancer drug in 20 years, 61% reduction in progression or death. Test for the IDH mutation early.
Second, the ADAPT-Sepsis trial. Daily procalcitonin-guided antibiotic cessation safely reduces antibiotic duration in ICU sepsis patients. CRP-guided protocols do not work and cannot be recommended. Advocate for procalcitonin protocols in your hospital.
Third, extended-release buprenorphine in pregnancy. Better abstinence, fewer serious adverse events, equivalent neonatal outcomes compared to sublingual buprenorphine. Discuss with your addiction medicine service for pregnant patients with opioid use disorder.
And quick hits. New PBS cancer listings for medullary thyroid cancer and follicular lymphoma. Broadened pediatric Crohn's disease biologic access. Triptorelin PBAC decision pending for women is health, and the time to antibiotics data reinforcing the 1-hour sepsis bundle.
See you tomorrow. Stay sharp.